Before we begin, allow me to introduce myself. I am Fatma Tariq, serving as an intern in Safdarjung Hospital, and I am a team member of OPTOBHARAT. It is my pleasure to guide today's session and ensure a smooth and engaging experience for all attendees. Today's session is on an important and insightful theme, and we are honored to have a distinguished speaker with us. Introducing the speaker, it is my privilege to introduce our guest speaker, who is Mr. Syed Imran. He completed his Bachelor's of Optometry from Centurion University. He pursued his Master's of Optom from Sankara College of Optometry, CT University. He has previously worked as a contact lens practitioner at Visakha Eye Hospital. Currently, he is serving as a research optometrist at the prestigious LV Prasad Eye Institute. With his strong academic background and clinical expertise, Mr. Imran brings a wealth of knowledge to share with us today. So let us welcome Mr. Syed Imran to begin his session. Sir, the virtual stage is all yours. Please start.
Good morning, everyone. Relax your accommodation. So, if your convergence is not that much good and you're not able to accommodate, obviously your near point will be lower than the expected value. So, that's the reason convergence insufficiency or basic exophoria will have low NRA compared to the normal individuals. So the second case is the convergence excess or basic exophoria, where you'll have greater esophoria for near, and will all any type of excessive conditions will always have high AC by ratio. So if it is an convergence excess or if it is an divergence excess, it will always have high AC by that. So for in these conditions, you'll also have PRA less and your amplitude will also be low in cases of convergence excess or basic esophoria. Now coming to any accommodative anomalies. See, in computer vision problems, rather than vergence anomalies, accommodative anomalies are more common than you think. So if the patient is having accommodative excess or accommodative insufficiency, how will you know that? So the one thing that you can do is you can do by accommodative facility testing, where you can do it monocularly or binocularly. So if the patient is having trouble with plus lenses, that means that the patient might be having accommodative excess. If the patient is having trouble with minus lenses, that means the patient might be having accommodative insufficiency. So if you are doing monocular accommodative facility and binocular accommodative facility, if there is problem with in both the condition, then it is a problem of accommodative issue. If the patient is not having the monocular issue and is having binocular issue with the accommodative facility, then it is an vergence anomaly rather than an accommodative anomaly. So the difference between these two is that monocular and binocular. If the patient is having trouble with both monocular and binocular, it means that it is an accommodative problem. If he or she is having only in binocular, then it is an vergence problem. So obviously, and the PRA will be low in the cases of accommodative insufficiency, the NRA will be low in the cases of accommodative excess. So you as the signs have been explained, you once you start to evaluate the patient, you need to do some tests that which have to be done for the some battery of tests which needs to be done if you are evaluating an orthoptic workup. The first thing is the standard tests that are vergence and accommodative test, vergence facility, vergence ranges, smooth vergence, step vergence, accommodation. Like you can do NPA, you can do accommodative facility. Uh, After that, you need to measure at 40 centimeters and at the distance where the patient generally sees their virtual digital screen. And you can also do MEM retinoscopy, which is an important diagnostic tool for categorizing which type of disease that the patient comes under. And in MEM retinoscopy, there is one instrument known as PRIO instrument, which is used to stimulate screen demand and which also improves diagnostic accuracy. So the PRA instrument is simply an digital screen that is placed on the retinoscopy while you are doing MEM. So it plays like an accommodative target, and the patient can see the target, and you can simply sweep out the retinoscopy. Why the pupil size is important while you are doing an evaluation? So the larger the pupil, the more will be aberrations. So the smaller the pupil, the good will be the depth of focus. So as you all know that while accommodating, your pupils will automatically constrict. So if the constriction is not happening, if the patient is having some pathological issue, obviously he'll have trouble with accommodation and near vision issues. So the seeing pupil size is also very important when you're evaluating these type of patients. And obviously, the tear film and ocular health is also very much important. So before going into any of these tests, it is very much important to see if the tear film and ocular health are good or not. If your tear film is not adequate, and if you are having any dry eye issues, any of these tests that you will do will obviously be false. You will be misdiagnosing, and your management plan will be disturbed. So it is very much important to see the tear film and ocular health before and after before doing your orthoptic workup. So, as I've explained previously about MEM, MEM findings with more than 0.75 diopters will indicate accommodative lag, and less than more in minus, if it is the patient is getting minus, then it is lead of accommodation. So, what is this accommodative lag and lead of accommodation? I'll explain it to you simply. So, suppose that you are seeing an near target at 40 centimeters, you need around 2.5 diopters of accommodation to see the target clearly. So what happens is that your accommodation gets stimulated, and for 2.5 diopters of accommodation required, you might stimulate around 2 diopters or 2.25 diopters, which is normal. So if your accommodative lag is more than 0.75 diopters, then there is an obviously issue with the accommodation. In the lead of accommodation, if you are like if you want to stimulate 2.5 diopters, you are stimulating more than that. If you are stimulating 3 diopters of accommodation, then you are overcompensating for that. So that is lead of accommodation that you can do with this MEM retinoscopy. Once you get those values, you can categorize which type of disease that the patient comes under. So while you are performing this test, if you are doing any cover test, if you are doing NPC test, what are the things that you need to look for? So obviously we'll do cover test. Everyone does cover test when they are doing their orthoptic workup. But the thing is that while you are doing cover test, it is very much important to control your accommodation. Until or unless you don't control your accommodation, the cover test results will not be accurate. How you can control your accommodation? You can always use an accommodative target, that is your near letters or numbers, during your cover test and alternate cover test. And while you are doing alternate cover test, there's a quick tip that you can do, is that while you are doing alternate cover test for near, how to know that the fusion has been breaked? If you occlude one eye, it doesn't mean that the fusion has been breaked. If you occlude, what you can do is that you occlude one eye, and from the fixated eye, ask the patient to look at a target, and you simply rotate the target there and forth until the fusion gets breaked. Once the fusion gets breaked, then you can perform alternate cover test. Then the Fourier values will be much more accurate. So you can do like that when you are doing cover test. And while you are doing a accommodative facility, many of us will have trouble finding out what type of flipper that we have to use, like at which age which flipper is appropriate. So simply you can calculate amplitude of accommodation, you can do NPA, and from that you can calculate amplitude of accommodation. From that amplitude of accommodation, 1 by 8th of that amplitude is your accommodative flipper starting flipper. So once you calculate amplitude of accommodation, you can do 1 by 8th of that, you'll have your accommodative flipper. So you can perform flippers by doing that. So while performing NPC, many of us will do this. We'll simply use an pen, or we'll simply use an pencil tip to ask the patient to see that pencil tip, and you slowly focus into the slowly tape forward. And once the patient experiences diplopia, you'll stop and you'll look for an recovery point. This is an like good procedure, but it is not a standard procedure. The standard procedure is that you have to use an vertical accommodative target. That is, you can use golden fixation stick, which is more like a scale, and you'll have vertical targets over that. And it is better if you use that target rather than a pencil or a pen tip. So how you can do, you can use that golden fixation stick and you can simply move forward, and once the patient experiences diplopia, then your break point comes. So why we are using vertical target rather than using horizontal target? So if you are using a horizontal target, your convergence can come act, and you can fuse that image, but you cannot fuse a vertically dissociated image. You cannot converge or diverge vertically. You can only converge and diverge horizontally. So that's the reason we'll use vertical target rather than an horizontal target while you're using while you're doing NPC. There is one other NPC that you can do, which is known as sensory NPC. So sensory NPC is something different from your objective NPC. Whereas in sensory NPC, you can check both your motor eye movement and sensory too. So if the patient is having any amblyopia, or if the patient is having any trouble with depth perception, obviously when you will do a pencil push-up or an accommodative NPC, the patient will not have diplopia. So that doesn't mean that the patient was not having any convergence related issue. You can always do sensory NPC and ask the patient to see if the lights are getting broken or not. The procedure is somewhat similar to your objective NPC. You'll place your red lens over on one eye, and you'll shine one light, and you'll simply go forward up until the line gets breaked into two up until the light gets breaks into two lights. It means that the fusion has been break and your convergence breaking point has been uh, got. So from that aspect, you can do your sensory NPC. And the other thing which I have noticed is that while you are doing NRA or PRA, so NRA break point is like NRA's end point is 2.5 diopters. It is constant for everyone. Why? Because when you're doing an array at 40 centimeters, if you're seeing an NA target at 40 centimeters, you require around plus 2.5 diopters of accommodation to get to see the target clearly. But if you're doing NRA and your target gets blurred at 2.5 diopters, it means that the patient is good. The patient is not having any accommodation issue. If the NRA is more than that, it means that he might be an undercorrected hypermetrope or an overcorrected myope. But the same thing cannot be applied to PRA. PRA is more like if it is more related to your amplitude. The higher the amplitude of accommodation, the higher will be the PRA. So if your amplitude is around 12 diopters or 13 diopters, obviously you will have more PRA. It doesn't mean that you have to do PRA up until the patient is experiencing blur point. If the patient says that if the patient says that it is not getting blur even at minus 2.5, you can simply stop that and you can write if it is more than minus 2.5. There is no point of doing PRA up until you are getting your blur point. So you can save some time while you are doing those tests. So these are the things that you need to look when you are performing any accommodative or convergence tests. Now the treatment or the management of these conditions is the first and foremost thing that you have to do is you have to give an appropriate refractive correction. After that, if the symptoms still persist, then you can consider added lenses, prisms, vision therapy. Obviously, you will see your ocular health and ergonomic issues, which are very important that I'll explain in the later slides. So the first thing you have to do is correction of emmetropia. So the first and foremost thing that you have to excel at doing proper refraction. Up until your basics are not right, you cannot give management, or you cannot manage the condition if you are not giving a proper refractive correction. So the first thing you have to do is you do an proper subjective refraction and you prescribe them glasses according to their needs. If the patient is having trouble with seeing digital screen at 50 centimeters, you can advise them task specific glasses. If the patient is already wearing the glass, you can adjust that prescription tailored to the screen distance. You can also consider some designs such as anti-reflective coating, blue block glasses, which is quite common nowadays. So we can also suggest them these type of designs. Now coming to proper refraction, uh, doing binocular balancing is very much important if you are treating a patient with VDT usage. Not every patient needs binocular balancing, because some of us work in a very hectic OPD, so we'll not have that much time so to do binocular balancing for every patient. But the patient who needs it, you have to do it compulsorily. So there is one method known as Borish delayed fogging method, which is very important diagnostic, like very important binocular balancing method, which is equal to your cycloplegic refraction. Well, how you can perform this? You'll do your objective refraction and you'll also do your subjective refraction. After that, you'll perform NRA. While you're doing NRA, you know that NRA needs to be done for near. You look for an sustained blur point. You'll add plus lenses in 0.25 or zero point 0.5 steps. After that, you will look for an sustained blur point. Once the patient says that the blur is sustained, then ask the patient to look at an distance target. Now, after that, you will use prisms and you dissociate the images. You can use a three prism base up or base down in both eyes, or you can use six prism base up or base down in any of the eye. So once the dissociation has been taken place, the patient will be easily appreciate the difference between the two images. So the key point is that you need to relax the accommodation completely in the both eyes. So once the prism dissociation has been taken place, you'll ask the patient which of the line, upper line or lower line, is more blur than the other. If the patient says that the both are equally blur, then there is no need to add any lenses. The patient says that one line is clearer than the other, you need to fog the clearer line and make the both lines equally blur. Once the once the blurring has been done, you'll simply remove the prisms and you'll slowly defog it up until the patient is able to read 6 by 6 line barely. Once he is able to read the 6 by 6 line barely, your binocular balancing has been completed, and the whatever values which you are getting, you can simply prescribe that. So there has been a study which has done previously 1 year ago, where they have compared binocular balancing using this Borish delayed fogging, and they have compared with the cycloplegic refraction. So the results were that these both refractive error values were almost equal to each other. So if you are not having any scope of doing cycloplegic refraction, you can always choose this method, that is Borish delayed fogging. So once you have done this refractive correction and you have prescribed glasses, and still after 1 month the patient is experiencing symptoms, then you can consider these added lenses. Well, added lenses are used in the cases of presbyopia. We all know that add lenses are meant to be given for presbyopia. But what if I told you that it is not only meant for presbyopia, but you can also give for some existential conditions where you will have where the patient is having high AC by A ratio, or if there any accommodative issues like accommodative insufficiency or ill sustained accommodation, you can always consider added plus lenses in such cases. It works good in the cases of accommodative insufficiency or ill sustained accommodation, but it is less effective for accommodative excess or accommodative infacility. So these two conditions are better treated with vision therapy rather than with added lenses or prisms. So coming to prisms, yeah, prisms can be given if there is basic esophoria or basic exophoria, or any small amount of vertical heterophoria is present. You can always consider giving prisms in such conditions. Well, vision therapy is like an advanced procedure where conditions like convergence insufficiency, accommodative excess, fusional vergence dysfunction, and accommodative infacility. In these all conditions, you can always advise them to go for vision therapy rather than giving, even if you are giving any refractive correction or added lenses, it will not help them to completely relieve of their symptoms. So they obviously need vision therapy. One other main important aspect is that while you're seeing a digital screen, your saccades and pursuits are very important if you are seeing something at intermediate distance. So the saccades are rapid jump movements between your screen, board, and your documents, which are main eye movements in your computer related tasks, whereas pursuits are helpful for smooth tracking movements where you are following something, where you are scrolling content. So if the patient is having any trouble with the circuits and pursuits, obviously he'll have to accommodate more, and this version's demand will also be more. So how it impacts on eye strain? If there is any excessive or insufficient inefficient circuits, it will increase the accommodative and versions demand, which will in turn cause visual fatigue. Poor pursuits will have trouble with scrolling content, where they'll have visual fatigue while they are scrolling content. How you can reduce that? You should optimize the ergonomics, and the documents which the VDT user is seeing, it should be hold beside screen, and the monitor position should be in the downward gaze. Basically what you have to do is the patient should not move his or her eyes that much frequently. So you have to minimize the eye movements and head movements. So according to that, you have to modify the ergonomics. So still, if the patient is having trouble, then you can always advise them to go for vision therapy for improving their circuits and pursuits. Well, I have said that ocular health is very much important before going into this accommodative and binocular anomalous cases. So, before prescribing any management plan, first you need to make sure that there is no dry eye related issue. Once you are sure that there is no dry eye related issue, only then you have to for then you have to proceed for the orthoptic workup. uh, the ergonomic uses, these are very important. Most of us neglect this. So the maintaining proper posture, maintaining proper monitor distance, the viewing angles, illumination, breaks, these all are very much important, as much as managing your prescription, or your prisms or vision therapy, whatever you are doing. It is also important to make sure that the ergonomic factors are very adequate and very much proper while they are using their digital screen. So here is an example of how an proper ergonomic use, like proper ergonomic setup has to be done. So as you can see, the patient's line of sight is somewhat in the downward gaze, which helps them to converge easily. If it is parallel, you will have trouble while converging. If it is upward, if the monitor is upward from the line of sight, you will also have trouble converging. So it's better to be in the downward gaze. As you're converging, your line of sight should be in the downward gaze. And as you can see, there should be and no glare from the monitor, and the screen should be easily visible. You can also use anti-reflective coating on the glasses. So these all will help to reduce the glare, and the lightning should be always come from the behind, and the back position and how they are sitting should be straight, and the back should be well supported. The chair should be adjusted properly. These all things you have to make sure that the patient is following. So if they don't want any mobility related issues. So now coming to the management, the first thing I have explained that you have to do proper refraction. If there is any amount of hypermetropia, if there is any amount of against through astigmatism, you should always prescribe that, and can always advise them anti-reflective coating glasses in order to reduce that flicker sensitivity which is coming from the digital screen. And environmental modifications can be done, like changing the lighting, changing the humidity in the room, and you can always manage the air conditioning in the room. So if it is not helping, then you can go for additional lenses such as add lenses, prisms, and vision therapy. So now we'll discuss two case scenarios. The first case scenario is an Priya, who is a 30-year-old computer engineer, where her main computer uses around 4 hours a day. While taking proper history, she said that her symptoms began to increase once the computer workload has been increased. So up until now, she hasn't got any prior examination. Her medical history was negligible. She is not having any issues related to systemic health. So after that, we got to know that she's using around 7 hours per day, and her keyboard distance was around 17 inches from her, and her monitor distance was around 23 inches from her. Her lighting was around a medium bright room, fluorescent lighting. So you have done your workup, and you got to know that her vision was 20 by 20 for both distance and near. While you have done cover test, you got that her distance was orthophoric, and for near she's having 4 diopters of esophoria. And when you have done AC by ratio, it was quite high. It is 8:1, and her NRA value was also 2.5 diopters, but her PRA was minus 1.75 diopters, and her MEM shows accommodative lag. Any other pupils, ocular health, and tear film were all normal. By seeing all this, we can say that the cover test is not normal, her PRA is not normal, her AC by A ratio is also not normal, her MEM is also showing accommodative lag. By seeing all these conditions, we can diagnose that the patient is having convergence excess with normal tonic vergence, where the issues are because of near phoria. What is the management that has been planned? The patient has been prescribed with bifocal glasses, plano for distance, and plus one near addition for near. So the reason, but we have chosen only plus one near edition is that as you can see her MEM retinoscopy, it is plus 1.5 diopters. The normal MEM should be around 0.25 or zero point 0.5 diopters. So one diopter is more. The one diopter lag is happening, and you can also see her AC by A ratio. One diopter of accommodation is causing 8 diopters of accommodative convergence, which is in turn resulting into esophoria. So if you prescribe plus one diopters, what happens to the AC by A ratio? It becomes from 8. It becomes from 4 esophoria to 4 exophoria, because one diopter is causing 8 diopters of accommodative convergence. So that's the reason we are giving plus one near addition for this case scenario. Uh, the goal is to reduce near phoria and improve comfort while they are seeing the computer screen. So you can always advise them bifocals. If the patient is like an early 30-year-old or 32-year-old, they'll have they'll be somewhat embarrassed to use bifocals. Then you can always advise them for single vision near glasses. Now coming to the case scenario 2, Ananya is an 24-year-old interior designer. Her main chief complaint was intermittent blur double vision when looking up at clients during computer work. So she's having double vision, not every time, but intermittently. So her history was around, this problem was present around from 7 years, and whenever she has visited to any eye clinic or any hospital, no one has diagnosed it. So she works in on laptop around 2 to 3 hours of her day. Her lighting conditions was variable because she needs to travel from one place to other place where the client is there. She needs to go over there. So the lighting conditions are variable for her. So while examining, we got to know that her visual acuity was fine. She is having 20 by 20 both for distance and near. But while you're seeing phoria, you can see that the distance phoria was 7 esophoria, and for near she is having 6 esophoria. So which is almost similar. The distance and near are almost similar, and her NFE values were also low. Her AC by ratio is normal. Her MEM was normal. So all other findings were normal except of the phoria. So by seeing all these values, we got to know that the patient is having basic esophoria, which is causing her intermittent diplopia. So what we have done is, if there is any amount of hypermetropia, we'll correct that. After that, you will give prism correction based on fixation disparity testing, and you got 4 prism base out, and you can give 2 prism base out in one eye and 2 prism base out in the other eye. So she has to work. She has to wear this for 4 weeks, and she has worn this for 4 weeks, and her symptoms got relieved. Later, she used these glasses for 2 years, and after that, she opted for vision therapy. So the take-home message is that if you're dealing with the patient with the VDT usage, and if the patient is having any binocular and accommodative problems, the first thing you have to do is the proper refractive correction is mandatory. We know that the dry eye might be causing majority of the problem, but you need to make sure that you use refractive correction you need to remember, if the patient is having any of these conditions, you have to prescribe these management for them. Well, this is the presentation for today. This is the topic that we have discussed. I hope everyone is clear with this. If you people are having any doubts regarding this, we can
Thank you so much, Mr. Imran, for such an informative and enlightening session. Your insights have truly added immense value for all our participants today. Now we will open the floor for a short question answer session. If you have any questions, kindly drop them in the chat box and we will take them one by one. So we have some questions. Reading or watching screen for 5 to 10 minute vision gets blurred. What is the issue?
yeah, if you're like if you're watching for more than 5 to 10 minutes, if your vision is getting blurred, the first thing that you need to do check is if you're having any uncorrected hypermetropia, because uncorrected hypermetropia can cause accommodative issues. So if you're having any uncorrected hypermetropia, you can uh, get corrected for that. And still, if you're having any issues after that, then we can do an orthoptic workup, and according to that we can plan your management. The first thing you have to do is appropriate vision correction has to be done, appropriate refractive correction has to be done.
Okay, so we have next question. What is normal value of NFV and PFV in near and distance?
Okay, so the normal values are present in Siemens book. It depends upon patient to patient, but the normal values for base in and base out values, NFE and PFE, are in distance. If you are doing NFE, you will not have blur, you will have break point and recovery point, which is around 15 to 20 for break and 16 to 18 for recovery. But for PFE, you will have blur, break, and recovery. In PFE, it is around the blur point will be around 8 to 12, and break point will be around 16 to 20, and recovery will be around 15 to 17. So there is one order that you can see. It is available in Siemens textbook. You can refer to that.
We have another question. According to the case scenario which you presented, for
Yeah.
Ananya, why we can't prescribe full cyclo plus power correction?
uh, for Ananya, the thing is that the whatever symptoms that she is getting is not because of not because of her refractive correction, but because of her heterophoria. So as I've said that like you can give them full cyclo plus the plus correction, but if they're still having heterophoria, then you need to consider giving prisms for them, because if it is an accommodative related issue, only then the plus lenses will be helpful. If there is no accommodative related issue, but still the patient is having esophoria, in such conditions you can prescribe prisms. So that's the reason for case scenario 2 we have prescribed prisms rather than going for an full cyclo power correction.
Okay, sir. Anyone else with some doubt or any question?
Imran, this is Pradeep. Okay, I have a
Yeah.
doubt.
Hmm.
Uh, when doing the membretinoscopy, if we
Yes.
are getting lag of accommodations, it goes to
Okay.
plus 0.75.
Hmm.
So, what is the
Hmm.
reason behind it? Why the patient is goes to plus lenses, lag of accommodations cases?
Sorry, Pradeep, I didn't got your question completely. Can you explain it further?
It means that while doing the membretinoscopy, lag of accommodation cases, patient having more plus power.
Hmm.
So, what are the main reasons behind it? Patients goes to plus power either with movement.
So the see in M.Optom retinoscopy, you are measuring the lag of accommodation. So the thing with lag of accommodation is that everyone will have some amount of lag. So as I've said in the previous example, if you are looking at any target at 40 centimeters, you require around 2.5 diopters of accommodation. but you will stimulate around 2 diopters or around 1.75 diopters. So the lag is around zero point 0.5 or 0.75 diopters. If it is more than that, then you will have more plus value. So then it will be considered as a lag of accommodation.
Okay, okay. Thank you.
Okay.
So we have another question. Does abnormal head posture affect the binocular vision?
Yes, yes. Abnormal head posture will affect the binocular vision because uh, the the first the first thing is that abnormal head posture has been developed because of an binocular vision anomaly. If the patient is having any vertical heterophoria or any cyclotropia or any cyclotorsion, the patient will obviously tilt his or head or tilt his head or change his head posture. Because of that binocular anomaly, he or she is having abnormal head posture. So obviously there will be an effect uh, for binocular vision if there is an head posture, abnormal head posture.
Okay, sir. So I don't think so. We have any further questions.
Okay.
Before we conclude, I would like to express our heartfelt gratitude to our speaker, all the participants, and the OptoBharat team for making this webinar a success. We look forward to your continued participation in our future webinars. Stay connected with OptoBharat, uniting future eye care leaders across India. Thank you, everyone, and have a wonderful day ahead. Thank you so much, sir.
Thank you. Thank you.
Thank you so much, sir.